Welcome to this Apkass webinar. Today, we're happy to talk about the topic of my strategy for chronic ankle instabilities. And we have a wonderful faculty arranged for everybody. We have Dr. Vega, Dr. Isamoto, Professor Han, and Dr. Hu. So without further ado, I think, let me introduce my co-host, moderator, Professor Hua. And
Hello, everyone.
I'm Samuel Ling from CUHK. So without further ado, I would like to introduce our first speaker. He's Dr. Vega. He's actually one of my teachers. So I went to learn from him from at the University of Barcelona. He's actually currently the chief of the EFAS, so the European Foot and Ankle Surgery Research Committee, and also the vice president of the MIFAS. So we're happy to invite Dr. Vega to tell us a little bit about this interesting topic of ankle microinstability.
Thank you, Dr. Lin, for the introduction. I'm going to share my screen, okay? So first of all, thank you to the Asian Pacific Knee Arthroscopy and Sports Medicine Society for this kind invitation. It's a pleasure for me to participate in this webinar. And thank you to you, of course, for the invitation. I hope that everyone is safe all around the Asian Pacific countries. So I will talk about ankle microinstability. This is a very, very common consequence as an ankle sprain, after an ankle sprain, especially in sports. As you can see here, she is Serena Williams in the last US Open semifinal, and you can see how she twists the ankle. Ankle instability as a result of an ankle sprain is about 10 to 12% of ankle sprains. And and this is not a minor problem, as you know. Instability is one of the most important joint alterations producing articular degenerative changes. And as you know, other intra-articular problems can be observed as soft tissue impingement, chondral problems, osteophytes, deltoid injury, and other as a consequence of an ankle instability. So here you can have an example. This is a young sports. He's playing, I remember, football, soccer. And in 1996, he has an ankle sprain. And then 20 years later, this patient comes to the consultation with this ankle. So now the problem is not the instability, it's all the arthrosis of the ankle. So as I said you before, ankle sprain is a common problem all around the world. And despite the frequency of this ankle sprain, the injury is often erroneously considered to have no consequences. And you can see here the numbers. In the United States, you have more than 100 million ankle sprain a year. In my country, more than 1.5 million people a year sprain the ankle. So this is not a few number. And we know that after every ankle sprain, there is always a lateral ligament complex injury. In the past, we considered that most of the patients that have complaints of their ankle sprain was because soft tissue impingement, but we currently know that probably the problem is a microinstability. So what is exactly microinstability? Is a mechanical ankle instability resulting from an ankle sprain, is as a consequence of an isolated superior fascicle injury of the anterior talofibular ligament. And when symptomatic, the patient has same symptoms that was described for soft tissue impingement: anterolateral pain, instability feeling, and recurrent ankle sprain. So to understand what is exactly microinstability, you have to know how is the anatomy. You can see here, this is an over dissection of the area, just to see ligaments on the bone. You can see here the anterior talofibular ligament with both fascicles, superior and inferior. In between, you have a small gap where ran this peroneal artery. When the sprain broken the superior fascicle and arrived to the peroneal artery, the patient developed this characteristic hematome in the area. Then you have the calcaneofibular ligament, and if you rotate a little bit more, you have the posterior talofibular ligament. But as I see this is an over dissection. When you have a dissection more conservative, you have all the capsule, you can introduce some air inside the capsule just to limit the capsule joint. And then you start to dissect at the limit of this capsule. You can observe, okay, here. So you start to dissect, sorry. Okay, you can start to dissect, and then you can observe here how one of the ligaments is inside the joint. This was never described in the past. That's the reason, because you can observe it in the lateral gutter when you scope your patients. You can see here, this is the superior fascicle of the anterior talofibular ligament. So we did study research of the anatomy of this area, and we observed too that there is a close relation between the distal fascicle of the tibiofibular ligament, which is also an intra-articular ligament, and the superior fascicle. There is a correlation, as you can see here, distal fascicle, tibiofibular ligament, or basset ligament, as Americans said, and superior fascicle. There is no continuity of fibers, but there is a continuity of the image. In contrast to superior fascicle, we have the inferior fascicle and the calcaneofibular ligament that have a close relation in between. They are both extraarticular structures, and they are connected by arciform fibers. These arciform fibers make that both ligaments, inferior fascicle of the anterior talofibular ligament and calcaneofibular ligament, works as a functional unit. And we name this functional unit as the lateral fibulothalocalcaneal ligament complex. If we observe here in this video how it works, you can observe here superior fascicle, inferior fascicle, calcaneofibular ligament. We can observe here the connecting fibers. We make a zoom of this area, and you will observe how the superior fascicle is relaxed in dorsiflexion and tight in plantar flexion, while the inferior fascicle and the calcaneofibular ligament, because of these connecting fibers, they are always tight. So then we have two different structures. We have the superior fascicle of the anterior talofibular ligament, which is intra-articular ligament. It is relaxed in dorsiflexion and tight in plantar flexion. And the inferior fascicle, the calcaneofibular ligament and its connecting fibers, they are extra-articular. It is an extra-articular structure, and they are always tight. We made at the same time a biomechanical study to see how is the function of each fascicle, and we observe as the superior fascicle just controls the talar internal rotation, while its inferior fascicle controls the anterior translation. So then we have two different structures. The superior fascicle is absolutely different than the inferior fascicle. That's why we propose this new terminology. And then the real anterior talofibular ligament is just the superior fascicle, while the inferior fascicle, calcaneofibular ligament, and its connecting fibers, they form this lateral fibulothalocalcaneal ligament complex. So according to this classification, to do this terminology, we can observe that in my experience, more than 90% of patients that we treat because of ankle instability, they have an injury only of this superior fascicle and not from the rest. So then most of these patients, they have only a microinstability. So what are the clinical implications? The injury of the superior fascicle of the anterior talofibular ligament provokes a microinstability. This fascicle is an intra-articular structure, as because of this, it will never heal when injured. This is really important because intra-articular ligament never heal after injury. In contrast to this, the injury of this lateral fibulothalocalcaneal ligament complex provokes a macro instability. It is an extraarticular structure when injured. If you immobilize, you have any change of healing. So how we have to diagnose microinstability? We have the history of and the clinical symptoms of the patients. We have the history of recurrent ankle sprain. We have anterolateral pain, instability feeling. And this is very important. As you know, this is a mechanical problem. In chronic situations, secondary intraarticular injuries are commonly observed. So then most of the patients come to the consultation because of the secondary problems, because they have soft tissue impingement, they have osteochondral problems, they have osteophytes, or maybe deltoid injuries. So remember this is very important. Every time you observe these patients with osteophytes or something similar like osteochondral problems, think that maybe the original problem is a microinstability. So you can observe here, this is a soft tissue impingement with this synovitis in the lateral gutter. And then when we remove the pathological soft tissue, you can observe here how there is an injury of the superior fascicle of the ligament, of the anterior talofibular ligament. So we try to validate this maneuver, the tibiotalar posterior driver test. Most of the people here in Europe, they call this maneuver the Vega test. This is very simple. The patient is in that position, and then we translate the tibia to posterior. There is a slight internal rotation of the foot. This way we can isolate the superior fascicle. If there is some translation when you compare with the contralateral side, so we can see that probably the patient has an injury of the superior fascicle of the anterior talofibular ligament. Stress radiographs doesn't work. I never ask the patient for stress radiographs. MRI, ultrasound. MRI, standard MRI is usually not useful for diagnosis of the anterior talofibular ligament superior fascicle. In this case, we cannot say here, this is the superior fascicle, but this is not the common vision on an MRI. Usually the radiologists, they can observe easily the inferior fascicle, but not the superior fascicle. So it doesn't work. Probably ultrasound is the best option, but you have to be really training in the ultrasound. And finally, the gold standard nowadays is the arthroscopic diagnosis. This is very important. You have to recognize normality. You can see this is lateral gutter in dorsiflexion, no distraction. Then you have distal fascicle of anterior tibiofibular ligament and anterior talofibular ligament superior fascicle. There is this image of continuity. So then if you observe something different to this, that means that the superior fascicle is injured. Recently we published this paper, the arthroscopic classification of ankle microinstability. This is really important that for you to recognize the injury. So you have type 1, this is a coma shape, there is continuity, but there is a really laxity of the ligament. Then you have partial tear of the superior fascicle. Then you can have medial detachment or proximal detachment. You can have complete detachment, and finally you can have a resorption of the ligament. So how to treat these patients? Of course, you have to repair the ligament. You can do a Bostrom procedure with this kind of incisions, but you have to remember that most of these patients, they have secondary intraarticular problems that you have to solve at the same time. So that's why we propose always to scope the ankle before to repair the ligament. But if you are really training in ankle arthroscopy and you can do this kind of evaluation by arthroscopy, why not to repair the ligament through an all-inside ligament repair? I don't know if Professor Han, he will talk about this, but yeah, this is a very common surgery nowadays in Europe. This is the post-op treatment. We usually mobilize the patient about 3 to 4 weeks, and then the patient starts physiotherapy. So what's the message to take home? Remember, after a mild ankle sprain, you will develop a tear of the anterior talofibular ligament superior fascicle, and because this is an intraarticular ligament, it will never heal. So the injury of this superior fascicle will result in a minor degree of instability or micro-instability of the ankle. This is not a minor problem and must be considered as a mechanical ankle instability. And as a result of a mechanical instability, concomitant intra-articular injuries are commonly observed. Finally, the ligament has to be repaired when conservative treatment fail. And I will always recommend the arthroscopic all-inside repair. So thank you for your attention, and for everybody, remember that you have your Congress, your annual Congress in Thailand in December. Thank you.
All right, thank you, Dr. Vega.
Hey, so thanks for the wonderful speech from Dr. Vega. Because we have no time for the discussion, so we would move to the next topic now, and I would like to introduce Dr. Shinji Ismoto. He is he's a clinical assistant professor from Nara Medical University, and we know Nara Medical University is toppest center for the foot and ankle in Japan. And Dr. Ismoto is the director of the Department of Orthopedic Surgery of Nara Prefecture General Medical Center. And his topic is we could see, why do we choose open repair for chronic ankle instability? As we know, the arthroscopic repair for the ATFL is a fashion now in all over the world. So I think this topic would be very helpful for us, for all of us, to consider about the technique again. So Dr. Shinji Ismoto, please.
Thank you, Dr. Huo. I have no COI. Introduction. Arthroscopic surgery for chronic ankle instability as CAI has become popular all over the world. From 2014, we also use arthroscopic reconstruction and repair. It is believed that all CAI can be treated with arthroscopic surgery, but we still use open repair. We want to present why we choose open repair. This is our open repair technique. Lateral capsule and periosteum of distal fibula were excised to make the L-shaped flap. If they are ossa fibrillare and osteophyte, we can see and remove it directly. Anchors are inserted into the fibula. Then lateral ligaments are sutured on the fibula. In this technique, loose CFL can be repaired. Our augmentation technique uses free graft of inferior extensor retinacle, IER. The graft is harvested through the same incision for repair. The graft is fixed on the teres and fibula by suture anchors. The results of our open augmentation are shown at mean follow-up of 8 years. Mean teratute angle and anterior drawer distance of stress radiographs were improved. Mean post-operative Carlson score was 19.6. Satisfaction rate was 85%. We use arthroscopic repair technique reported by Takao. This technique can repair the ATFL tear, but it cannot repair the CFL tear. We use anti-roll technique reported by Takao for arthroscopic reconstruction. Advantages of arthroscopic surgery are minimal invasion, less pain, preservation of soft tissue, shorter recovery time. So we choose arthroscopic surgery for the patient with CAI from 2014. This slide shows the 60-year-old female basketball player. We performed open repair and augmentation for left ankle. After operation, instability improved. Then we performed arthroscopic repair for right ankle. After operation, their tilt angle was improved, but instability remained. What should we learn from this case? From 2014 to 2019, we performed arthroscopic repair in 12 patients, 30 ankles. Mean JSSF scale, mean tear tilt angle, anterior distance were improved, but instability remained in 2 ankles with tear tilt angle over 15 degrees. In our experience, indication of arthroscopic reconstruction is same as open reconstruction, but indication of arthroscopic repair is not same as open repair. It is not known whether open repair and augmentation is replaced by arthroscopic surgery. To decide the indication of each procedure, lateral ligament injuries are divided into 4 types. Type 1, loose ATFL and intact CFL. Type 2, loose ATFL, loose CFL. Type 3, poor ATFL, loose CFL. Type 4, poor ATFL, poor CFL. In open surgery, for type 1 and 2, repair is chosen. For type 3, repair and augmentation with free IER is chosen. For type 4, ATFL and CFL reconstruction is chosen. Lateral ligament injuries sometimes have ossa fibrare. Some ankle have an osco at the insertion of the ATFL. The other ankle have an osco at the insertion of both ATFL and CFL. With ossa fibrare, sometimes augmentation is needed to reinforce the defect after resection of osco. In arthroscopic surgery, type 1 is the best indication of the arthroscopic repair, and type 4 is the best indication of arthroscopic reconstruction. What do we choose for type 2 and 3? We cannot repair CFL by arthroscopic repair. Should we choose arthroscopic reconstruction for them? With subfibrare, should we choose arthroscopic reconstruction to reinforce the defect after resection of osco? The choice between open repair augmentation and arthroscopic reconstruction is controversial. In the open repair and augmentation, there is one incision of the ankle. Suture anchors are used for fixation. On the other hand, in the arthroscopic reconstruction, there is an invasion of the knee for the graft harvest, and 3 large bone tunnels are required for the graft fixation. We think open repair and augmentation is lower invasive than arthroscopic reconstruction. How about arthroscopic prostrom good procedure? Good clinical results were reported, but this technique is not anatomical. Good technique was reported to result in restricted range of motion. In this reason, we do not use good procedure. How about internal brace? Good clinical results were reported, but it is difficult to insert the anchors as the best position after repair. So we choose open repair for type 2 and 3, and augmentation with free IR is added for type 3. With ossa fibrillary, arthroscopic repair is performed for only the patient with small osco, easy to remove. This slide shows 25-year female with small os subfibrillary. Arthroscopically, osco was removed and repair was performed. This slide shows 16-year male with big ossa fibrillary. By open surgery, osco was removed and repair is performed. We retrospectively investigated our procedures for CAI in 225 ankles. Procedure for ATFL. 88% of ATFL tear were treated by repair or augmentation. Only 12 needed reconstruction. Procedure for CFL. About half of the CFL did not require treatment. They are type 1. They could be indication for arthroscopic repair. 32% of CFL require repair. They are not indication for arthroscopic repair. Comparing the procedure for CFL with and without ossa fibrillary. Most of CFL with ossa fibrillary did not need reconstruction. They are good indication for open repair. Recently, our most popular surgery is open repair or augmentation. Conclusion. We presented our strategy for CAI. Indication of arthroscopic surgery is limited. Open repair and augmentation is lower invasive than arthroscopic reconstruction. Most cases with loose CFL or ossa fibrillary are good indication for open repair and augmentation. Thank you for your attention.
Thank you, Dr. Isomoto. It's quite interesting. I think most of us would agree that some clinical scenarios may do better with open repair, but I think a lot of the attendees would debate which one, open or arthroscopic, would be better. Now, it's my pleasure to introduce our next speaker because we are running short of time, so the question and answers we'll put to the very end. So our next speaker is Professor Han. He's a professor at the Gangnam Severance Hospital at Yonsei University. And well, he will actually tell us about arthroscopic lateral ligament repair for chronic ankle instability. So without further ado, Professor Han, please. Thank you.
Okay, so I'm going to present you one of the representative methods in arthroscopic lateral ligament repair for chronic ankle instability. My presentation is mainly focused on technical videos of our method. As you know, the modified Brostrom operation for chronic ankle instability is now a gold standard and show good clinical outcomes in many previous studies. However, Nowadays, many orthopedic surgeons are trying to improve its technique for better results. Considering open surgical lateral ligament repair, we had several drawbacks, such as combined intra-articular pathology management or deterioration of the proprioceptions. Also, the modified Brustrom operation showed about recurrence rate up to 15%. In our previous study, chronic ankle instability had above 95% combined region rate, and this combined region did affect the clinical results after Brustrom operation. The following figure illustrates the common combined regions of the chronic ankle instability and its arthroscopic findings. Therefore, the arthroscopic surgery is now an essential procedure in ligament repair surgery, and many ankle surgeons had investigated ankle ligament anatomy and modified the knee and shoulder arthroscopy technique suitable for ankle arthroscopic ligament repair. However, the technique of ankle arthroscopy did not rapidly develop compared to other joint surgery due to the complexity of the ankle anatomy and difficulties in visualizing the ankle structure by arthroscopy. But nowadays, many surgeons are trying to arthroscopy ligament repair and getting more popular. In South Korea, about 20% of the foot and ankle surgeons are utilizing arthroscopic surgery for ligament repair. The advantage of the arthroscopic ligament repair is now as follows, especially the faster recovery and preservation of the proprioceptions are noticeable. However, this technique still has several problems to overcome, such as technical variations and running curve for beginners. Today, I'd like to show our preferred two arthroscopic ligament repair technique. Before showing the videos, we needed to make sure the anatomy of the ATFL and CFL. Also, Dr. Vega shows the very precise anatomy of the ATFL. And as shown in this picture, the ATFL is originated from the 10 millimeter from approximate to the tip of the fibula and 5 to 7 millimeter distal to the inferior border of the AITFL, and inserted 5 millimeter inferior to the anterolateral border of the talar dome, not on the talar neck. Therefore, the random marker of the drill hole for suture ankle is located about 5 to 7 millimeter inferior to the border of the AITFL. According to this anatomical study, these three arthroscopic ligament repair techniques are commonly used in our country, and I will show you today the various modified technique and the loop suture technique by the Dr. Takao. At first, I will show the Dr. Takao's loop suture technique. This technique used the 1-2 strand suture anchor for ATFL repairing. Another additional suture anchor is used to reinforce the retinaculum. This is relatively simple and it can be easily applied. Here's the videos. After the finding the ATFL, we use the lasso to put in the wire. Then we make a drill hole just above the ATFL and put in a suture, one suture anchor, which has 2 strands of the suture. And wrap up the ATFL by using a grasper. Okay, here's the procedure. And then we tie the 2 sutures and attach the ATFL to the fibula side. And this is the video displaying how to reinforce the inferior extensor retinal by percutaneous technique. So after putting another suture anchor through the anterolateral portal, then we sutured percutaneously and reinforced the inferior extensor retinaculum like this method. This knockout technique is possible only when the ligament remnant exists and the talar attachment site is intact. If the patient has generalized laxity or attached the ligament from the talar side, this technique could not be performed, as Dr. Isamoto said. Also, the simultaneous suturing of the CFL and the use of this technique is an attenuated case where ATFL does not exist is an important technical issue to be elaborated in near future. And I'm going to show you modified narrow technique. This is maybe the way to complement the Dachau's technique to some extent. The original narrow ligament repair technique can be summarized by suturing the ATFL and the inferior extensor retinaculum together. In our technique, we are using 4 strands of suture anchor for ATF and CFL together with the inferior extensor retinaculum. This modified technique is originally practiced in capsular shifting technique in recurrent shoulder dislocation. This modified technique can be used in cases when the patient has attenuated ligament or has a generalized laxity. Here's a video. At first, using a probe, we have to find the ATFL or its remnants. As you can see, the most of the ATL was attenuated, and we can find just a small bundle of the ATFL. Then we have to make an anterolateral accessory portal for suture anchor insertion. Then we have to make a hole using a drill bit just below the AITFL, which showed you in a previous slide. This is very simple, so just we can find the inferior border of the AITFL. Then we insert 4-strand sutures in ankle joint and check stability like this. Then we pull out the 1 strand to the anterolateral portal, the inferior ATFL, inferior to the retinaculum. This is video how to pull out the 1 strand of the suture anchor to the anterolateral portal. Maybe these 2 sutures is used for to reinforce the ATFL and the inferior retinaculum. Then using a Russell wire, we passed another suture strand just below to the CFL area. These 2 other sutures are used for to reinforce the CFL area capsule. So through the accessory portal, we passed the Russell rule just below the CFL remnant like this. As you can see this video, so using a wire, we passed another suture just below the CFL area. And finally, all the strands of the sutures are positioned properly, like this, maybe you can see the all sutures surrounding the lateral capsule of the ankle. Also, the all sutures are positioned properly at the extra-articular safe zone. The safe zone is bounded by the sural nerve and the superficial peroneal nerve. Then, using a curved mosquito clamp, anterior two strands are passed to the accessory portal through the inferior retinaculum, and the posterior two strands are also passed to the accessory portal percutaneously. Then, all strands in the ankle are tied in neutral position. After completing the tie, check the stability of the ankle. Including our technique, still we are collecting the data. However, the arthroscopic ligament repair shows another excellent clinical outcome in many cases compared to the open brustrum technique. And the technique may be compensated some special case, and is a challenging point now. So this is summary, and our is overviewing of our arthroscopic treatment for chronic ankle instability. So in summary, if the ligament remnant doesn't exist or patient has general laxity, we can have two choices. As Dr. Izumoto said, we can do the open repair. However, the modified native technique is another option for treatment of this kind of patient. Thank you very much.
Thanks for the great presentation from Professor Han. I think we could discuss at the end of all the topics. So now let's move to the next presentation. Let me introduce Dr. Peter de Hoo. He's Chief of Surgery and Acting Chief Medical Officer at the Apkass Orthopedic and Sports Medicine Hospital in Doha, Qatar. And he is also a sports medicine, very skillful sports medicine doctor. He is a professor at the Liège University, CHU, Belgium, and the assistant professor of orthopedic surgery at the Weill Cornell University, USA, and the University of Rome, Italy. And also, he is the chairman of the East Coast Young Professional Task Force and past chairman of the Leg, Ankle, and Foot Committee. Now, his topic is syndesmosis, managing the athletic high ankle sprain and RTP. So please, Dr. de Hoo.
Hello, everybody. Thank you, Professor Hui, Professor Jung, Professor Ling, and the whole team. It's really a pleasure to join you, and we miss you all. It's been too long, dear friends. And thank you for indulging me in the micro instability and the open and arthroscopic repair. It's always great to see the innovation. And I want to thank you all for allowing me to present our humble research lately on a topic that might be related more than we think to the current topic, which is the syndesmosis. Now, our focus is basically on the sports-related issues around that and the return to play. And I will try to proceed with the presentation. And greetings from Doha to all our friends. I have no disclosure to this talk. Now, when we talk about syndesmosis, we talk today, the next 10 minutes, about an isolated syndesmosis injury. Why? Because we will not talk about deltoid, nor really chronic treatment options, nor fracture-related options, because that's not at the scope of this talk for the moment. I would like to share with you the video that you see now, and you look at the landing of this player. So the goalkeeper brings him out of balance. It was about 6 years ago. We think it's a minor ankle sprain, but look at his face. This is a Brazilian national team player that just had an ankle sprain according to the data that is presented from the team doctor. Now, you and I know that this is not the case. Why is it not the case? Because it is not an ankle sprain. Now, our journey started about 6 years ago, where we had the chance to, in all our athletes, do an MRI after an acute ankle sprain within 7 days after the injury. What did we see? We saw that 20% of our athletes on MRI suffered with an acute so-called ankle sprain, evidence of syndesmosis injury. So where we say that an ankle sprain is an inversion plantar flexion injury and a so-called high ankle sprain is a dorsiflexion eversion injury, there is much more related to it than we thought. And I was so happy to listen to Professor Vega, his talk, because that is exactly what we believe as well, more from the non-anatomical, but more from the functional point of view. And if you go further with me, you look in the epidemiology, when you have a new idea or you see things that you don't understand, we look at what's out there. Now, I can guarantee you we did an in-depth search and there is nothing on return to play, nor on the functional evaluation and follow-up in rehabilitation after treatment for isolated syndesmosis injuries. And we had the chance to team up with the UEFA Champions League database, where we over 15 consecutive seasons controlled 3,500 plus players, and we evaluated the injury incidence and burden. And what did we see in isolated injuries at the highest level of soccer for the moment? We saw that the injury incidence during match play, as you have seen on a video, was 14 times higher, that there is an annual increase by 7.5%, and that most injuries are contact related, with an abscess that extends much more than the classic ankle sprain abscess. So this is, for the first time, we have an idea on what's going on in the elite stage of sports on isolated syndesmosis injuries. But of course, that doesn't mean anything if you don't go more in depth. So what did we do? We went to look in the literature on how to evaluate that. And we had, in orthopedics, we like to keep it simple. So we came up with the listen, look, feel algorithm. You listen, what happened? You see on the video which type of mechanism it is. And then you see if there's also combined medial pain. Is there any radiation up, which is not typical for ankle sprains? You look at the imaging, you look at your specification of X-ray, whether it's stress X-ray, ultrasound, or MRI, which you are comfortable with. And then you look at the feel, where is the provocative testing. You all know very well these type of tests and their value, but that's so far for the match so-called high ankle sprain. This is a video that was sent to me a few weeks ago when the training in Premier League started again. And very simple, this player came out of balance after a touch, no contact, no match, just a simple training. And you see how he, on the right foot, comes completely out of balance and really goes in that dorsiflexion, external rotation injury. Now, I would like to share with you a sort of bit of controversial idea. When you look at that video, and when we look at what we are all trying to do, which is understand better what's going on, you have to look furthermore. You have to look like in the anatomy, you have to look with your arthroscopic tools, but you also have to look at other joints. Now, if you look at that mechanism that you just saw, you have to acknowledge that there are striking differences with the so-called ACL injury in the knee. What do I mean by that? We want to propose, and again, it's coming out of our field of clinical assessment, we want to propose to remove the term high ankle sprain, because it makes no sense at all. It's not an ankle sprain and it's not high. So it is related to the ATFL, as you have seen in the superior fascicle, and therefore it is related to the ankle. Now we call this injury a syndesmosis pivot, because it's a pivot like in the knee. The only thing that is different, and we actually believe that the foot steers that, the position of the foot decides whether you will have a syndesmosis injury or a knee ACL injury. Now, we've just published that idea. We would love with all the teams to discuss that, see the criticism and hope we can elaborate further on that, because we believe that that mechanism of injury is strikingly similar, and also that would reflect on tackling techniques, on prevention techniques, and hopefully even on treatment techniques. But that's for the future. How do we evaluate that? Well, you can go in grade 1, 2, and 3 of isolated syndesmosis sprains. I don't have to go too much in detail. Grade 1 means a small one, never surgery. Grade 3 is everything broken, always surgery. The problem is, most of the time you have grade 2 injuries in 81% of time. And then we come into the gray zone of maybe surgery. And maybe doesn't mean anything when you have your athlete in front of you who's asking pertinent questions. So then you look in the literature to the algorithms, and you look if there's stability or no stability in that grade 2 of the syndesmosis injury. And it's helpful to know whether there's a combined deltoid injury, whether there's a radiation up IOL tenderness, or whether your external rotation and squeeze tests are positive. Sometimes the X-ray is helpful, but in the end, there is no real pathognomonic sign to know whether it's stable or not. And therefore, most of the time, with our athletes, we tend to jump into the golden standard, which is arthroscopy. But that means that you will scope a lot of your athletes for no reason at all. And therefore, we propose to develop a kind of demo based upon our data from cadaver lab, opening of the syndesmosis, and adding our technology from the biomechanical lab to that. We came up with an idea to blind the physiotherapy demo that we made with an arthroscopic finding. And strikingly, when you go in 20 degrees of dorsiflexion with that device, you can actually have 100% hit with what we saw in arthroscopy, meaning we believe that in the future, there will be more and more chance through a non-invasive procedure to identify whether you have a grade 2A or a grade 2B. So to be continued. And of course, you can look at the X-ray, at the overlap and the clear spaces. Of course, you can have MRI, CT, and dynamic sonography if it's available in your center. And until now, what we are talking about today mainly is the diagnostic arthroscopy to evaluate syndesmosis, to evaluate combined injuries, and to treat them. Now, how does it look like? On the left, you see 2 pictures of arthroscopy, seeing where the AITFL fascicle falls into the joint, lower one where the IOL falls into the joint as well. On the right side, you see the deltoid injured. You see on the right lower side, a real cut in the deltoid from an arthroscopic point of view. I really hope our next webinar will be on a deltoid arthroscopic repair, but hopefully that won't take too long and we can all team up to evaluate not only the new and fascinating insights and research behind the ATFL, CFL complex, also the syndesmosis, and hopefully in the future, we finalize together the deltoid. Now you have 2 types of tests. You can do the shaver test or the hook test. What is the idea? The idea is that when you can push your shaver or your hook 4.5 millimeter into that distal syndesmosis and turn it, it means that you can have a grade 2B. Now, a grade 2B, what does that mean? That means that it's unstable, but in many cases, we say it's expert opinion. What does that mean, expert opinion? It means that you've done a lot and you have a feel for it. But there's nothing on literature or nothing throughout the world that we can call similar nomenclature or similar guidelines or recommendations in line with our golden standard arthroscopy. So we have arthroscopy as the best tool, but we don't have validated measurements to say it's stable or not. So that's why we came up with the idea to put a dynamometer on our arthroscopy, push into the syndesmosis, like in an arthroscopy, the forces required, documented, to enter, and then gradually cut the ligaments and see how much force is required. And these forces are now hopefully in the future a start to bridge the gap between golden standard arthroscopy and creating validated measurements in order for us to all speak the same language. We're not there yet, but I hope this can help in order to get furthermore and to have a better idea on stability or no stability. And then we come to the treatment part, where you have screws, where you have suture buttons. You're all very aware of it, about the pros and the cons. I don't have to go in detail on that. And I actually believe that we are beyond that discussion. Both have pros, both have cons. It's at your preference, depending on if there's a combined fracture, a combined diastasis, a combined deltoid problem, a combined cartilage problem. It's all based upon the individual case where you can choose from at your preference. The real problem, however, is the remaining malreduction. In our series of reviews, we have seen that although we believe that we're on the right track with isolated syndesmosis injuries, especially in fractures, there's still an incidence of 52% malreduction, with the remaining diastasis after proper fixation by proper surgeons, proper experienced surgeons, don't get me wrong, by 22%. So although we believe that we do the right thing, these numbers make us humble, all of us. And these numbers tell us that we have to improve. So do we have the proper diagnostic tools? Gradually, yes. Do we have the knowledge how to fix it? Gradually, yes. But is it over time what we really want? Probably not. So I have the pleasure to announce you that we did a systematic review recently on the value of our fixation techniques in malreduction. And it was well received by the American Journal of Sports Medicine with the award of 2019 systematic reviews. And if you would like to read it, I'm more than happy to bring it to the table. But in a nutshell, it says, whatever you do, just focus on malreduction and use the tools to avoid that to the maximum, because it's still the problem out there. And then you will say, how do you evaluate malreduction? Well, that's the next topic, because we don't really know. If you look at the comparative CT scans, if you look at the post-traumatic morphology of that distal syndesmosis, it's very variable and it cannot guide us in the best way for the moment. So how can we improve? We were planning with our team of leg, ankle, foot in Apkass to present you a really cool international return to play survey that we did on isolated syndesmosis, where we really saw not only what the foot and ankle surgeons nowadays use, but also very strikingly and very interestingly, what is the geographical differences in the use of these tools. So what works well for one, what works well for the other, and maybe come up with a general guideline. So you are all welcome to hear it, hopefully in the next Apkass in Cape Town. And I would like to finalize this small message about isolated syndesmosis. From epidemiology to diagnosis and treatment, we would like to finish with the return to play. And again, strikingly, if you look at literature, there's very few papers that really help us to tell the patient, if you have a grade 2B, if you have a grade 3, what can you expect towards return to play? Because that's actually, as you all know, the #1 question. Now, what we did is look at our series of the last 5 years. We've identified 110 male professionals that had grade 2B or 3, and we evaluated in our series of return to on-field rehabilitation, return to train with the team, and return to first match, what is the timeline that you can expect? And although these are just numbers, actually, I see them as very helpful to show your athletes, first of all, that you're interested in the topic, and second, that you can give a sort of guideline, a framework where they can work towards to. So in summary, you have the return to on-field training and first match, but when you have a grade 3, it is quite extended. Now, that's not strange, but we have seen that is mainly due to the fact of age, due to the fact of combined deltoid and combined cartilage injury. And these 3 are a predictor for delayed return to play. And if there's anything more than happy to discuss on the recent work we did with all the teams. And I feel very privileged to share that with you today and to team up furthermore. And thank you again.
Thank you, Dr. Ju. So I think, we had a very, very interesting night. I thank all the speakers. Professor Hua, do we have time to answer some questions from the audience?
Yeah. So I think
so I see Dr. Vega has actually answered a lot of
yes.
the questions individually. Well, I think, because of time, I think that it's been a very wonderful talk. I think you would all agree. Dr. Vega showed us some very, very nice cadaveric specimens and all the ATFL and the anatomy. I thank Dr. Isamoto for his wonderful work on the open repair and how he showed us that in some clinical scenarios that we probably do need to go back to open repair. Thank you, Prof. Han, for showing us your wonderful skill in the arthroscopic repair and all that for the lateral ligament. And in the end, thank you, Dr. Duke, for the wonderful talk about something a bit higher up, but even more mysterious, I would say, than the lateral ankle ligaments, and that is the syndesmosis. So I think it's been a very wonderful talk. Thank you, everybody. Before we end, I must do one thing, and this is to invite everyone here. So we have 140 something attendees today. The Apkass meeting is still on. We hope that it can be one of the events that can restart our world after this COVID and all the pandemic. So please register. Submit your abstract. We still have a little bit more than a month to submit your abstracts, and we hope that we can see you all in Thailand in the beautiful Pattaya exhibition and convention hall. So thank you, everybody, and we hope to see you at the next Apkass webinar. Thank you.
Thank you.
Thank you. Bye.
Wonderful.
Thanks, Dr. Isamoto. Thanks, Dr. Peter. Great to see you.
Hey guys, I miss you. How are
Thanks,
things?
Dr. Han. Great presentation.
Dr. Duke, can I just ask, so for your return to play, do you have any sort of criteria on your examination or what they do, or, since you look after so many elite footballers?
Yeah, there's actually, that's the next step, Samuel, because if you look at the systematic review that we presented a few years ago in, I think it was GISACOS, we saw that from more than 10,000 papers on return to play, on ankle sprain treatment, that only 5.5% of them, which was almost nothing. It's such a common injury, it's such a commonly treated injury, but there's no real return to play guidelines or steps towards. So what the physios do is work towards discharge criteria, and they have established that now, not really in a validated way, but quite structured. If you look at the syndesmosis, they actually treat the syndesmosis similar. Even the physios that I work with, they do neuromuscular training, stability, proprioception, and it sort of works. The thing is, if you really go in depth on it, the mechanism is completely different. So it can't be that is the best way to treat your syndesmosis rehab-wise. So if you're going to use your discharge criteria for your syndesmosis, just like your lateral ankle sprains, you get away with it. It's quite forgiving, but it's probably not the right way. And maybe, even maybe, that might be why the rehab time for syndesmosis is longer than for ankle sprain. So my message is that we need to find discharge criteria for syndesmosis specifically based upon the mechanism of injury that we always do. But we're not there yet.
Because it's always, we have this dilemma in our clinic also. So what actually happens? How do we actually treat these patients? It's very interesting to hear, especially if we're going for elite athletes. Sometimes the treatment, we all know, would be a little bit more different, or maybe a little more aggressive, I would say.
Yeah.
Okay, I have a question for Jordi. So Dr. Vega, so thanks for the wonderful presentation and great job. So do you think that the inferior bundle of the ATFL is just an extended part of the CFL? So because from your presentation, I can get the conclusion that exactly the true ATFL is just the superior part bundle of the ATFL, right? So
Yes.
yeah. So do you have any evidence from the anatomy? For example, the fiber of the inferior bundle of the ATFL is just a continuous, the same fiber of the CFL.
So you have the fibular connections. There are close connections with the CFL.
Yeah.
When you compare origin and distal insertion of the superior fascicle and inferior fascicle, they are really different ligaments. Really different ligaments.
Okay.
And for the ligament complex, for this lateral fibulo-talocalcaneal ligament complex, you can observe in the fibular insertion of both calcaneofibular and inferior fascicle, you can observe how fibers are really connected in between. So one of the questions in the chat was, when you repair the inferior fascicle, you are tightening at the same time the calcaneofibular ligament. And this is true. This is true. The problem is, it is enough when you have a completely tear just to repair the inferior fascicle? And the answer probably is no. Probably in a completely tear of inferior fascicle and calcaneofibular ligament, you have to repair both at the same time. Otherwise, I don't know what happens with the subtalar joint. Probably for the tibiotalar joint will be enough just to repair the inferior fascicle and not to repair the calcaneofibular ligament. But for the subtalar joint, probably is not enough. So then you have to repair both at the same time. But everything is connected there. So the truth is that superior fascicle is a different structure than the inferior.
Thanks. So the other question I have is the other question about we know there is a very small ligament called lateral talar calcaneal ligament, right?
Yeah.
It's
yeah.
So while in your anatomic images, so we could not find this ligament. So
So probably this is not a real ligament. This is part of these connecting fibers.
Okay, I see. Okay. Thank you.
Yeah, that sometimes you can observe when you dissect the area, sometimes there is a reinforcing in the area of the connecting fibers. And these are this lateral talocalcaneal ligament. But this is not a real ligament. This is connecting fiber.
Okay, okay.
Jordi, can I ask you something?
Of course.
First of all, I really never had the pleasure to meet, so looking forward to future meetings.
Yes, sure.
Now, when I do an arthroscopic procedure, and when I compare it to an open mini brostrum, with my open mini brostrum after procedure, I really have a feeling it's fixed. Where when I do that with my arthroscopy, although the results are really good, I'm happy, I don't have that same feeling. Why is that? And second, when you are, for example, fixing, and you have your arthroscopic fixation, and that's a really question to the whole group, and you fix it, you've done your job, and then you think, you know what? I'm happy, it's in place, it's there, I feel with my probe it's there, but I don't trust the tissue. Do you have anything as a recommendation when you have fixed that, what you could add? Would you add the Neri procedure? Can you help me out? Because I have the feeling with my brostrum, I always have a plan B open, where I don't always have that feeling with arthroscopy.
Yeah. So that's a good question. That's a good point. I don't know what kind of arthroscopic technique do you use?
We do the push lock. We do the push lock, but I have no disclosure.
Okay. So I had the same feeling in the past. Sometimes you repair the ligament, and if it's an isolated repair, you say, okay, maybe if the patient start to move in 10 days. I don't know if the repair will be enough. And that's why I immobilized the patient 3 to 4 weeks. The problem was that after 3 to 4 weeks, the patient has a really ankle stiffness. And then you have to send the patient to the physiotherapist, to a strong physiotherapist. Sometimes there was a stiffness in plantar flexion. So I decided to change a little bit. And now I repair the ligament, and with the same sutures, I make an internal brace. So I always use this technique, the all inside repair and this suture augmentation, when it's a young and active patient, for example, one professional, you do this technique, and the day after, the patient can start to move. Yep. If you do other procedures as hindfoot endoscopy, then you need to mobilize faster, and you repair the ligaments at the same time. 2, you have to reinforce with a suture to start to move the day after. Same for osteochondral problems, same for patients with bad quality of the ligament or bad ligament repair. So then you reinforce with the suture, and then you forget, because it's protected with the suture.
Right.
Yep. Now I always use a technique which Dr. Vega described just now, and I love it. And I think it's could be a salvage procedure for the patient had a poor quality of ATFL, while you do not want to reconstruct it. And for the first question, I think maybe for the repaired ATFL, it need not to afford a very high load, as Dr. Takao had by mechanical test research that the repaired ATFL only afford about 100 and for after the when the patient started to walk normally. So I think we do not need a very strong fixation. Maybe that's an answer. So also Dr. Giza, as I know, published in biomechanical research that the arthroscopic technique could have the similar strength, fixation strength comparing to the open procedure. Yeah. So I have a question. I have a question for Dr. Shinji Isamoto. So as you mentioned, you have 4 types of the ligament injury, right? So for the first one, you can use arthroscopic repair, while for the patient with a poor quality of ATFL, while combined with loosened CFL, you select the open repair. So I'd like to know why not use arthroscopic repair of CFL combined with arthroscopic reconstruction of ATFL, because also I think the technique is similar as arthroscopic repair or reconstruction.
Now I have no technique to repair CFL arthroscopically.
Okay, I see.
So we can only repair ATFL only. So if we should repair CFL, we choose open repair.
Okay, thank you.
At the moment. If the procedure advance, we in the future we want repair CFL.
Yeah. So thanks. I have a similar question for other doctors. So do you do the arthroscopic repair for CFL?
Mhm.
So in my case, if it's injured, I always do arthroscopic repair.
So,
So I try to avoid open surgeries.
okay. So how could you identify the CFL is loosened or is tight during the arthroscope operation?
So, yeah, first of all, you have to go to the lateral recess. And then if you see there the peroneal tendons, for sure, the ligament is injured. And sometimes you can observe because there is a small hole in the capsule, and then you can see both peroneal tendons. If not, in these cases, you have to open a window in the area, and then you will see the calcaneofibular ligament. The other option is to go extraarticular, as Dr. Guillo is doing. He goes extraarticular, and that's the same. I prefer go intraarticular and then open a window in the capsule just to see the calcaneofibular ligament. Of course, if the calcaneofibular ligament is injured, that means the inferior fascicle is also injured of the anterior talofibular ligament. And if you can see the calcaneofibular ligament arthroscopically, so then you can repair too.
Yeah, of course.
Yeah.
So how about Dr. Han? How about your experience?
Yes, in my experience, I totally agree with Dr. Vega, but it's very hard to see the CFL through the arthroscope. But just I get reinforced the inferior area of the ankle capsule where the CF maybe exist. So, and I do the modified Neri technique when the patient has a subtalar instability or the patient has a CF rupture by the MRI or ultrasound examination. Yes.
Can I just ask?
Yeah.
So, I mean, the CFL, if you don't repair it, what's your experience of just not repairing it and maybe just repairing the ATFL? Did your patients suffer that much?
Yes. So after I learned the Takau's techniques, I just repaired ATFL only. The most of the cases are failed because of the subtalar instability. So I always do the reticulum reinforcement. Maybe the Dr. Gyongtae Lee, he published the paper before that reinforced the inferior reticulum may work as a CFL. So they make cover the subtalar instability. Yes. So I always do the reticular reinforcement when I'm doing the Takau's technique.
Right.
So Peter, how about your experience? Mute. We could not hear your voice. Yeah.
So sorry, I just had my hospital on the line. Can you repeat the question, please?
So would you like to, or could you repair the CFL arthroscopically? Or do you think it's a need or it's a don't need?
Yes, look, I thought it was impossible. I went to some cadaver lab sessions, learned from the guys who invented it. And actually, I have found it pretty straightforward since then. But that is a credit to the people who have really gone in depth in the technique. And with the right tools, you can actually really go to the subtalar joint, identify the area of the CFL. Still, the question is about the nerve. Still, the question is about the positioning. I've learned to really identify my landmarks pre-operatively well and try to accommodate that with my surgery. But now I have been able to improve in my technique. Again, thanks to the giants who have made it. And I think some people have been amazing on that to show us how to do it with their amazing skills.
Okay, thank you.
Okay, thank you all for the lively discussion. I think we've actually gone over time for 20 minutes. So I'm sure there's so much we can still talk about, but I'm afraid we should probably say goodbye. and we'll see each other sometime later. Thank you.
Bye bye. Thanks.
Thank you.
Thanks.
Thank you.
Thank
Bye bye.
you. Bye.